Good evening, everybody. Today we are going to take one of the cases of the nasopharyngeal carcinoma that already you have Dr. Bilal instructed you or just Dr. Mahmoud Fishawi to do the planning for it on the Beam Hub. I will start with a small introduction about the nasopharyngeal carcinoma, then we can proceed with the case. I will share my screen right now. Just tell me if you can see my screen.
Yes, we can. Yeah.
Okay, we're gonna to talk about the nasopharyngeal carcinoma, not the lymphoma in this type. First of all, for a small introduction for the nasopharyngeal carcinoma, it's the most predominant tumor type arising in the nasopharynx. The nasopharynx is the tubular passage behind the nasal cavity. It's uncommon in USA, but WHO have seen it's common in southern China and Hong Kong. We have two peak incidents for the age from 15 to 25 years old and from 50 to 60 years old. It's more common in men than in females. The nasopharynx is the tubular passage that behind the soft palate. It's the most superior one of the pharynx. It's bounded superiorly when talking about the borders. It's bounded superiorly by the skull base, inferiorly by the soft palate, anteriorly by a nasal cavity, and posteriorly by posterior pharyngeal wall. Here we can see in this light blue one, this is the nasopharynx. Below it, the oropharyngeal pathway, then the hypopharyngeal pathway, and here we have the larynx. This is a lateral view CT scan of the body. As we can see, the borders of the nasopharynx are the skull base superiorly. Anteriorly, we have the nasal cavity, and posteriorly, we have the posterior pharyngeal wall. Inferiorly, we have the soft palate. Laterally, we have the medial trigoid plates with the pharyngeal constrictor muscles. I will show you a lateral view of the nasopharynx right here. This is the nasopharyngeal cavity. This U-shaped is the beautiful fossa of Rosenmuller, one of the landmarks of the nasopharynx. We have here two bony landmarks, the medial trigoid and the lateral trigoid. These are the infratemporal fossa, and this anteriorly we have these nasal cavities anteriorly. So in the nasopharyngeal cavity, we have this fossa of Rosenmuller, and inferior to it, we have the turris tubularis, and we can see here, this is the part of the Eustachian tube. Looking again, we have this CT scan axial of the nasopharyngeal, the starting of the nasopharyngeal cavity with the turris tubularis part and the fossa of Rosenmuller, medial and lateral pterygoid plates. We have here the masticator muscle. Anteriorly, we have the nasal cavity, and posteriorly, the posterior pharyngeal wall. Here are the posterior pharyngeal wall, and this is the styloid process. One of the cases that we had that you have prepared it for planning was for a 45 years old male complained of a nasal tone of the speech along with left-sided neck enlargement. And nasal endoscopy revealed a left-sided nasopharyngeal mass obliterating the left fossa of Rosenmuller. PET-CT has confirmed an FDG avid bilateral nasopharyngeal masses, more in the left side. SUV was 10, which is very high, along with bilateral enlarged neck nodes, levels 2 and 3, level 2 and 3 on the left side, and level 2 on the right side. The largest was on the left side, 3 by 5 centimeters. Upon pathology, the histopathological examination revealed a non-keratinizing undifferentiated nasopharyngeal carcinoma, and unfortunately, it was Epstein-Barr virus positive. This is the CT scan of the case. We have here enlargement in the left side of the nasopharynx along with the right. The right is also enlarged, and the left side is more prominent. And we have here a left-sided neck node with a right-sided level 2 and left-sided level 2 neck node. These are positive upon FDG avid PET-CT. Upon staging AGCC cancer classification, we are here a mass more than 2 centimeters. We are in T3 and bilateral neck nodes, so we are N2B, N2C, sorry. So we are T3, N2C, M0. staging. We are stage 3. Upon discussion in our MDT regarding the tumor options and the best option for this member, the decision was to receive an induction chemotherapy. Induction chemotherapy in the form of the docetaxel, cisplatin 5-FU, then a concurrent chemoradio. The patient already received the induction chemotherapy and he showed a very good partial response after the induction with a residual nasopharyngeal mass and neck nodes. After the induction chemotherapy, is the radiotherapy is the cornerstone of treatment along with a concurrent cisplatin weekly. The dose prescription for this patient was a 70 gray over 35 fractions over 7 weeks, a conventional fractionation using VMAT technique, and this is what's available in our institution. For assessment of radiotherapy, the patient should be offered for a multidisciplinary team for the best treatment option, and for the dysphagia and the mucositis and the possible side effects that occur during radiation therapy, he must go for an adequate dental, swallowing, and nutritional evaluation before starting radiotherapy. The aim for the treatment plan is for the localization of the gross tumor and the target volume, the optimization of dose fractionation, and determination for the best technique for the member, patient positioning, immobilization, then the precise radiotherapy treatment delivery. Upon simulation, the patient was set up in a supine position with a neck hyperextended, with immobilized head and neck thermoplastic mask covering from the head vertex, the skull vertex to the shoulder. We may use a mouth bite to decrease the dose to the oral cavity, but we didn't do in our patient, this for the simulation. CT scan with IV contrast could be a better option. Pre-chemo MRI and pre-chemo PET CT is essential for the definition of the gross target volume. CT MRI fusion or CT PET fusion would be preferred with the pre-chemotherapy and post-chemotherapy investigations. This is the patient with the head and neck mask. I think that we are all familiar with this setup. We started with the definition of the gross target volume of the GTV. The GTV should receive the full dose of a 70 gray. It includes the all gross disease in the nasopharynx and the neck nodes that are more than 1 centimeter, or any nodes that have a necrotic center. When we showed this CT, we have here the left-sided nasopharyngeal mass. With this is our GTV for the nasopharynx, and these are one of the lymph nodes that were one of the gross target volumes in the also nasopharynx that were avid on the PET-CT. Looking down, we can see here that enlarged lymph node that were pre-chemo and post-chemotherapy on the right side. On the left side, this one is amalgamated lymph node. These are the targets for the gross tumor volume. After we start delineation with the of the GTV, we put a margin of a CTV 70, which could include any microscopic or clinical disease. Then we take a PTV 70 over the CTV 70 according to the margin and institutional margin in our institution. CTV high risk for the nasopharynx, it's subclinical disease. We give a 60 gray over 35 fraction, or a 59.4 over 30 if we are using fractionation of 33 fractions. The CTV of the high risk includes a lot of parts of the nasopharynx. It must include the entire nasopharynx along with the GTV 60, the anterior two-thirds of the clivus, the skull base, the pterygoid fossa, parapharyngeal space, inferior sphenoid sinus, posterior half or fourth of the nasal cavity and the maxillary sinus, inferior soft palate, the retropharyngeal lymph node, the retrostyloid space, and the bilateral neck nodes from level 1B to level 5. When we started delineation for this member, this was the highest level for the CTV 60 or the CTV high risk, included in the inferior sphenoid. Then we started taking the posterior maxillary sinuses and the skull base, along with going down. We've taken the pterygoid fossa. We have here the medial pterygoid plate and the lateral pterygoid plate, and these are the gross GTV that we have already delineated. We have to take all of this area of the pterygoid fossa and the parapharyngeal space, and to include all of this cavity in our CTV high risk. Going down, we have to take all of this parapharyngeal space, this black space is the parapharyngeal space. We have to take it in our CTV high risk, including the lymph nodes. Going down, in our axial CT scan, we can see here that we taken all the nasopharyngeal cavity along with the parapharyngeal space with the bilateral neck nodes. Then we have taken here level 1B. We have the patient was a positive in level 2 on the right side and the left side. So in the CTV high risk, we have to include the submandibular lymph node. So this was extended to receive the bilateral submandibular lymph node. And going to level 2 and 3, going down in our axial CT, we have taken level 2 bilaterally and level 3 bilaterally, and giving and going posteriorly for level 5 lymph node, as we have positive lymph nodes on on both neck. So level 5 should be covered in the high risk group. CTV high risk was ended at level 3, and on this case we have received level 4, bilateral level 4, as a CTV low risk, which is CTV 54. So going down here, we started to delineate our CTV 54, which is the low risk, from posterior sternomastoid here to the midline, and going down to take whole level 4 posterior to sternomastoid, going down posterior to sternomastoid, and this is the lovely esophagus, and this is the spinal cord, going down to end our CTV 54 just above the sternoclavicular joint. We have three PTVs. The PTV 70 should include the CTV 70 along with the margin for the setup errors and the patient position, the CTV high risk, which is the CTV 60, the margin around the CTV 70 that we already delineated, and the PTV low risk, which is a 54, a margin around the PTV 50, CTV 54. Sorry, this is an error, CTV, not PTV. We have to delineate a lot of organs at risk in the nasopharynx. This is one of the advanced head and neck cancers. We have a lot of organs at risk for delineation, including the brainstem, the optic nerves, the chiasma, the spinal cord, the parotid glands, the value for the IMRT, and the VMAT for the sparing for the parotid gland, the oral cavity. The patients during radiation could may suffer a lot of mucositis, a lot of dysphagia. So we have to know the doses for the oral cavity, the doses for the esophagus, along with bilateral eyes and the lens and the glottic larynx, the cochlea. We have to delineate all of these organs so that we can assess in our plan. I have taken this lovely table from the Nancy Lee, the famous Nancy Lee book. NCCN also gives us another normal tissue constraints for the mandible, the temporomandibular joint, the brachial plexum, and all of them. It's almost the same according to our institution. We try to use the most convenient normal tissue dose constraints to provide us with a very lovely dose volume histogram that we can receive. Thank you. I think that Dr. Bilal will provide us with planning for this case.
Thank you, Dr. May, for all clinical information about this case, the nasopharynx case. Thank you.
You're welcome. Do you have any questions?
If you have any question for my, you can either type it in or raise your hand, and I can pass the on to you. No, no questions. Dr. May, I have like a couple of questions, if you don't mind.
Sure.
So I see here you have like the margin you mentioned, like 3 to 5 mil meter margin in your CTVs. Uh, Based on what you decide, what margin you are using or you are going to
The
do.
mod the modern is institutional, as you know.
Mm-hmm.
According to the setup errors, our
Yeah.
physics colleagues could provide us with the margin they can to achieve a good planning. We
Mm-hmm.
use in our institution 3 millimeters
Mm-hmm.
for margin, but this is institutional from a site to site.
Sure.
Maybe it's according to the setup positioning before the radiation, before every session, and for the DRR and the com beam CT that we receive that we do for the patient before every
Yeah.
session.
Oh, perfect. Thank you. Another question for the, you mentioned that you have like lots of risk organs to outline. Do you
Mhm.
rely on or use like any auto contour tools, like any of the one of the market, or you have to go through this yourself and spend a good bit of time?
Personally speaking, I do it myself.
Okay.
I know that a lot of planning systems have now contouring atlases for the
Mm-hmm.
organs at risk, but I do it myself. I do
Yeah.
trust myself. And a lot of things, when we do the contouring, the automatic one that it's in the planning system, sometimes
Mm-hmm.
and a lot of times I have to repeat them. It's not that
Okay.
accurate, so repeating it would waste a lot of time for me instead of doing it from the start. But
You prefer to do it
some of
yourself.
my,
Yeah.
yes, I do, I prefer to do that actually. But some of my colleagues, they rely on the atlases that are in the planning systems right now.
Yeah. Okay. I have a question here actually. What is the RTUG number you are using for the constraints?
Let
I
me
think
check.
RTUG 0, Dr. Muhammad, I think it acceptance criteria for this case, RTUG 0615.
Thanks, Dr. Ramay.
Thank you
Please,
all.
Dr.
Thank you all.
Thank you, Dr. Ramay and Dr. Muhammad, for your question. I will start from where Dr. Ramay is went. I will back again to part for simulation. This is the important part for our patient to start with the radiotherapy, to take the radiotherapy treatment. The CT simulation is a very important part, and the for case nasopharyngeal to the physician and the physicist also, to take the patient best treatment without the deviation treatment for all the treatment session from the end to end test. We'll start from the CT simulation. The patient, as the doctor may said, the simulated at spine position, and the therapist will align the patient and place the plastic headrest underneath the head neck for support, to make sure the patient is comfortable with his session. Immobilization device will use the thermoplastic mask to mobilize the head and the neck, and make sure the patient without the moving the shoulder and without the shift for the rotation the patient during the treatment. The therapist will proceed to align the patient and make sure the laser and make the radio beaks the tattoo, and make the CT simulation with do the CT simulation the scan with the small thickness, because this the patient nasopharyngeal the crowded area for the organ at risk, the contouring and the BTV, for make sure the create the contour with the high precision without the division, the clinical contour, the GTV and the CTV, and the transition to the BTV and the organ at risk also. After that, this is the image, the familiar with the nasopharyngeal mobilization device. We'll start with the contouring, as the Dr. Mai mentioned. For this part, we have, for this case, the CTV and the GTV and the BTV. We have the three BTV, the common in the common case in the nasopharyngeal. BTV 54 and the BTV 60 and the BTV 70. And the organ at risk we have in this area, the crowded area, a lot of the organ at risk we have the brainstem and the brain and the cochlea and the optical pathway different the organ at risk. We have the optic nerve, the chiasm, and the pituitary gland, and the mandible, oral cavity, pharyngeal, constrictor, and the spinal cord. We need to mention here in the sum the R2G, the acceptance was the criteria we plan evaluated for it. The BRV will create for the two organ at risk. Not all the organ at risk. We have just the commonly the margin the added for the BTV. Just for example, the spinal cord, the brainstem, and the chiasm. We add the common the margin min 3 and to the 5 millimeter. The based on the WBM or the R2G WBM, the most the common the follow the BRV to the organ at risk task group 263. The contouring part, we have the 3 BTV 70 and the BTV 60 as we seen, BTV 54. The contouring the part, the very important area to build the physicist his plan. Note, do not modify the physician drawn contour. This is the important note, just we focus with it. The physicist, if we add or the change or the make the new BTV to get the best plan, can duplicate the BTV, not make the modificate for the BTV drawn by the physician. Contouring will help your optimizer to achieve the best plan. Planner will cook his plan. This part, very important, not neglect this contouring part or the ahead for the contouring part before the start and go quickly to make the new plan. We need to check the contouring part for get all information about the patient and check if the crowded area organ at risk, the overlap with the BTV. Please check before start and communicate with the physician to get the best plan and the optimizer go without the conflict between the organ at risk or the BTV. We'll start with to our BTV. I will explain the 3 ways to adjust and get the coverage for the BTV in the planning system, Eclipse planning system. 3 ways. We will get the best plan if the select anyone from them. I will start from first way to get the best coverage for the BTV and also the achieve the criteria for the organ at risk. Crop will start the first way, the crop BTV from each other. We have in this case BTV 54 include 50 BTV 60 and BTV 70. How to manage with the different transition dose? I will explain in this way. First way, we have the high dose from the BTV 70 and the BTV 60 and the BTV lower dose for the BTV 54. How to overcome this problem? If we suppose the objective for the BTV 54, if we put for the upper objective in the optimization process, for the 54 will control the overdose in the 54, will make the underdose for BTV 60 and the BTV 70. Will the overcome this problem? We make the crop to our BTV from the each other. We'll start to explain as this area will make the crop the BTV 54 from the BTV 60 and the BTV 70 and make BTV 60 also the crop from BTV 70. We don't make the BTV crop for BTV 70. We had no higher dose from the BTV 70. It would be to create optimization structure, make a new name for the BTV without make any modification from the BTVs that room from the physician. We duplicate and the duplicate from each BTV and make new name for BTV 54 as optimization BTV 54 and also BTV 70. Will crop BTV 54 is cropped 0.3 centimeter, 3 millimeter from the BTV 60 and assign the upper objective make for it optimization process the zero. This is the just explanation, the simple way. I will go to more information about how to manage it. But to explain the more, BTV 54, if we cropped from BTV 60, we can easy to manage that with the make upper objective to BTV 54, put it the zero upper objective without to get underdose for BTV 60. This is just the simple explanation for crowded BTV we have with different transition dose. Optimization structure for BTV to create the margin will flow the rule how to make the crop our BTV will flow the rule 5% each 1 millimeter from the BTV. If we need to explain this area, if we have BTV 60 divided 70, we have 80%, 85%. We have now to make the crop for BTV 60 from BTV 70. We flow the rule 5% each 1 millimeter. Now we crop BTV 60. BTV 60 include BTV 70 by 3 millimeter without underdose if the BTV optimization BTV 60 in optimization process without get underdose in BTV 70 without the division the dose near to the edge of the BTV 70. And if we again to explain how to manage the 54 include all BTV 60 and the BTV 70. If I make the example, no, I will again. Now we have 25% divided 5. Our rule, we make BTV 50 optimization BTV 54 crop by 5 millimeter from BTV 70. This rule we will flow to make the BTV crop for each BTV optimization. We will put it in the optimization process. This is the first way to overcome this the problem. The BTV 54 include all BTV 60 and BTV 70. There will not be have BTV as I said optimization BTV 70 would not have higher dose from BTV 70. Alternative method for modify the planning target, we have another way can use it to make the optimization process without make BTV crop. We can use just directly the BTV contouring from the physician. I will explain also for this way how to control it, and we will get the best result for the BTV without make BTV crops from the each other. Each BTV inside to the each other, we can contain this CC. If we have the 54, for example, if we have BTV 60, 300 CC inside BTV 54, 700 CC. We can put 42. I will share my screen to explain this point. See in this screen BTV 54. We put the value. We get it inside 43.5 and control the upper without the BTV crop from the BTV 70. Can you see in this area upper CC we put 43.5 the near to the CC BTV 70 also, and can do that with BTV 60 and the BTV 70 without add BTV crop from each other. Can explain again? BTV 70, we have the CC 372, can divide it BTV 60 CC, we get 52% volume can put in upper objective, and the control by the dose 64 without create the BTV crop 60 from BTV 70 and get the result. If this way can get the result and another way can get the result. Now in Eclipse we add another option, BTV crop. The new version from the Eclipse can do as the Monaco user. We can control from the BTV, just put the crop option, check, and the BTV they exclude to each other without make any extra way. These three ways can control BTV from each other and overcome the problem we have the BTV inside to each other without get the underdose from it. The latest version, as I said, the auto crop with the different BTV feature is now available in the Eclipse. If we don't have this option, can use the optimization BTV crop from each other, follow the rule 5% in 1 millimeter from each other, the crop the BTV 54 and the BTV 60 from the 70. And alternative method, we have modified the planning target volume without to add the BTV crop from each other. Just see how much the volume the BTV 70 inside the BTV 60 and the divided BTV 70 cc divided on the BTV 60 will get the value that put in the volume and the control the upper the objective. This this the screen. They explain the optimization BTV. We'll put it in the optimization process. The BTV 60 they exclude from the 70, and the optimization 54 they exclude the 70. Organ at risk in the nasopharyngeal case, with sometimes the overlap with the nodal volumes. For the example, the parotid, the overlap with the BTV 70, and also sometimes the oral cavity inside the BTV 60. This the crowded area contoured by the physician, but sometimes the organ at risk, the overlap with the BTV. If there are significant overlap, such the parotid, pushing the parotid to meet the constraint will the result in under the covering the BTV. Sometimes they need the before the start and the put the objective parameter in the optimization process need to communicate if we get the underdose in the area of the BTV and without the get the result, good the result to the organ at risk. Or can the physician can modify the BTV before the start to make the crop from the organ at risk 0, or the can accept the underdose for the BTV and the saving the area to the organ at risk. Tips and the tricks for the organ at risk, I will explain another way to the physicist to how to overcome this problem with the organ at risk, to create the BRV to organ at risk. If we have parotid, for example, we can add the margin around the parotid to make control more the dose outside from the BTV, different transition BTV to parotid organ at risk, and or the make the oral cavity the crop from the BTV with the 0 or the crop from 3 millimeter can push the dose inside the BTV without the under the dose. Also, the larynx can solve with this area by the add the larynx the crop from the BTV and add the larynx plan, name the another plan the larynx plan with the optimization process. Add the values the upper the object with the different volume to facilitate and the relaxation to the organ at risk. This, if we had the organ at risk overlap with our BTV, can overcome this problem with add the mini upper in optimization process can overcome with and achieve our criteria for the organ at risk. This is the problem with the organ at risk overlap, in this case, the nasopharyngeal, brachial plex, and the thyroid gland, the overlap with the BTV60 and the BTV70, the brachial plex. Sometimes we need to communicate with the physician, and if the organ at risk, some organ at risk cannot achieve, if the patient high advanced case and the need to achieve the best treatment without the under the dose if the patient already advanced case. Optimization structure. This is the case. In Eclipse planning system, we can adjust the different transition. In this case, the nasopharyngeal, we have the BTV60 and the BTV70 and the BTV54. All BTV in some axial cut in the same edge. How to overcome this problem? We will mention now to how to solve this different transition with get the optimal plan without the underdose for different the BTV. The Monaco can solve this problem by the patient, control the different the transition. In Eclipse, we can get the best the result with different transition we have in this plan by the create the first plan, first ring around the BTV, and the second ring around BTV60, and the third ring around the BTV54, and the fourth ring, the common ring in the Eclipse or the in nasopharyngeal case, the post neck or the avoid to make the avoid arc in the shoulder region. If we don't do the avoid sector to make the freedom your arc. We'll start to explain the ring one around the BTV crop by 1 millimeter from the BTV. As I explained the rule, 5% in 1 millimeter. If you don't, how to create your ring through this rule and get the good result for the ring structure. Our first ring around the BTV cropped by 1 millimeter from BTV. Second ring around BTV60, cropping by 1 millimeter from the BTV, but avoid. We have problem in the ring when created ring BTV60. In the same edge, we have the BTV70. To overcome this problem, we need to crop again from the BTV70 by 3 millimeter to when we put the value for the upper objective, we can get the result. We don't under this area for the BTV70. If we see in this area, the BTV ring 60, just 1 millimeter, but from the BTV70, 3 millimeter. Ring 3 around the BTV54 cropping by 1 millimeter from the BTV, but avoid to BTV60 by 3 millimeter and also 5 millimeter from BTV70. We can see ring 54, the 1 millimeter from BTV54, and at this area we have BTV60 and the BTV70 also. We cropped 3 millimeter from BTV60 and 5 millimeter from BTV70. This to if you create this ring, as I explained, we don't get any underdose from the different level dose. And the final ring, boost neck and the avoid. This created to the avoid if we don't make the avoid sector for your arcs to avoid get the higher dose at the shoulder region or the beam, make the modulation and this the region to push the dose inside without get the higher dose in this area. We start the geometry, the beam and arc arrangement, but first point will focus with it, put your isocenter. In Eclipse, we have the MLC 120 MLC. In the center, we have the smallest leaf width and the outer large leaf width. I advise when create this plan for this nasopharyngeal, put your isocenter, put your isocenter arc at center of the largest BTV volume to this take the full modulation with the small leaf width. Common arcs to nasopharyngeal case by bilateral lymph node. Using the full arc, it is recommended use 2 full arc clockwise and anti-clockwise. And the arc optimization process uses the 20 and 340 kilometer angle. We have the extra option in the Eclipse if we need to the arc geometry recommendation. Can click from the planning. We get the arc geometry recommend for you the collimator and the arc clockwise and anti-clockwise, and if you add the 2 or the 3 as recommendation. Please note the degree of the collimator I used for this case. Notice the limited degree. Use the rotation collimator as you want to fit your BTV. If you have any different case, tongue or the larynx, fit your collimator based on your BTV shape. I will need to focus in this area. We have the limitation, small limitation, as the Dr. Mahmoud Al-Fishawi said in the last presentation. We have the limitation for the MLC, the maximum leaf span 15 centimeter. We overcome this problem. We create the one field to make to the cover. I will explain in this problem first. This slide I will explain in this slide. If we to explain for Eclipse users how to understand this problem, MLC, the maximum leaf span 15 centimeter. If we treat this 2 target in one arc, we lose your modulation as this mark. I will explain this. The lose your modulation in this area. But I advise for you to overcome this problem. We split our arc, the first arc to cover first area, and the missing area we will cover by another arc. I will to understand this area. Dr. Mahmoud was talking about it. This MLC leaves the specification, the thickness of the MLC leaves. The central leaf are the thinner, I said that, and can therefore modulate the dose more intensely and precise to take the full advantage if put your isocenter at the center of the large BTV to cover all the BTV with the smallest leaf, and you will get the best modulation for your plan. The distance the MLC leaf of X-jaw travel, the MLC leaves of the X-jaw that travel a laser distance 15 centimeter relative to the MLC leaf of the Y-jaw. And so it might be dosimetrically advantage to limit the distance that travel by these leaves if the target volume is longer than 15 centimeter. You lose, as I said, use your modulation, best modulation, because that I advise for you. The split for first arc, the interest area, and the opposite arc, we will cover the missing area. This plan I created for this case. First arc, the split, and another arc will split and get the best result. Optimization tips. The starting optimization with the BTVs and the rings. I advise if you don't familiar with the nasopharyngeal case, how to make the plan, start your plan BTVs and the arcs. Can also use the new option in the Eclipse, normal tissue objective. Normal tissue objective, this is the new option in the Eclipse. I will explain this option, the work as the Monaco, if the Monaco user will hear in our presentation. The patient they make the quadratic in the Monaco plan, and now the Eclipse, we can the normal tissue objective, the work, the make the virtual ring around the BTV and the pushing the dose to inside and the more control to the different dose level outside the BTV. Note it could be the advantage to pass the level 1. During the start, the optimization, I advise for you the recommendation, the both level 1. Level 1 during the our optimization will the process, follow the process, the 4 levels. The level 1, the best if you have higher modification for the BTV, priority, and the rings and the organ at risk. I will explain in this slide. The both hold the level 1 for the add media different the upper objective for the BTV or the organ at risk, both, and the hold for the level 1 add one by one for the organ at risk to get the best result for the plan. And after you get the smooth the curve without the spark the peak, will get the best DVH and the best the coverage. Again, deactivate and get the best result and complete the level 2 and the level 3. Level 3 can make small modification again if you have both this level and follow this parameter and the DVH. If you get the best the coverage and the organ at risk, the acceptance the criteria as you want, again the complete the level 3 and the level 4. I will again to explain the normal tissue objective. Normal tissue objective can work manual or the automatic. If you want to work the normal tissue objective, the automatic can put the priority relative to the BTV. If you start with the BTV 100, you can put normal tissue objective 100 also to 120. If you want to more pushing the dose inside the BTV, can you modificate the normal tissue objective by manually put the priority first and the distance from the target? As I said, this is the work as the Monaco planning system, the overdose, quadratic overdose inside the patient, the control by different margin with the millimeter. Here, the normal tissue objective work as the Monaco, the same the concept, make the around the BTV virtual ring and more control for your different dose outside the BTV. Start BTV and rings. If you start your plan by BTV and the rings, put your BTV 100 and the rings with my experience with different creating the nasopharyngeal rings, put 75 or the 50 and the rise slowly to the make the best the control for your BTVs. Optimization tips: adjust your BTV with the lower. We control and get the best BTV coverage with two objectives we have in Eclipse optimization process: the lower and the upper. Lower objective, we put the prescribed dose from the physician as prescribed, and the upper we control the maximum dose inside the BTV. Start the priority with 100 to your BTV. Note to prevent the dose level from the hotspot, as I said and explained, the optimization BTV cropped or the optimization BTV 60 and the BTV 70. If you use the first way I explained, optimization BTV crop from each other, can do upper can use freedom without afraid from the underdose inside the BTV 70 or the 60. But I will explain in this slide. Optimization BTV 54, but the lower dose as the prescribed dose from the physician 54, and the volume volume the cover all the BTV 100, and the upper we put the volume the 0 without afraid for under the dose, and they get the best result. And the dose the upper objective the 55, and the same the work in BTV optimization BTV 60. We control the upper by 0 from the 70 without under the dose, and the lower the 60 prescribed dose from the physician, and cover the 100% volume for our the BTV. and the BTV 70 can put prescribed dose 70 and control the upper dose. And then we make the different rings. Started our ring by 75 until to get the best control to our dose. And if we split the dose outside, we can make the higher the priority for different rings. Objective during the level 1, if we make the hold for the level 1, can add different upper to the organ at risk one by one, and see the result for the organ at risk. If the chief start the organ at risk with the 50 priorities, and then can add the mean dose for the organ at risk accepted for the accept by the mean dose, or for the organ at risk accepted by the upper. For the example, the brainstem or the spinal cord can control by the upper objective. This the second way. I will explain again for the second way. This way, Dr. Mahmoud Al-Fishawi, I will talk I talked with him about this method. He used this method and I get the result, and I used it, get the better result. If the start the BTV 54 and the control without the BTV cropped from the BTV 60, and the BTV 60 crop from the BTV 70, will get also the better the result. If we start the BTV 54, the lower can put it as prescribed, and can add different lower for the BTV if you want to add the BT lower different the volume 99.9 or 99.5 can add different lower for your BTV. But upper BTV 54 we have we include BTV 60 and the BTV 70. BTV 54 as we see in this slide, the upper BTV include BTV 54 include the BTV 60. If we put the volume percent, the close this the volume by cc, this the near to the volume BCC, and the BTV 70 include the BTV 50 BTV 54 include the BTV 70 with the volume as I explained this this way. We will see here the BTV volume, the upper, the close to the number for the BTV 70 volume BCC. Plan evaluation, we evaluated this plan at least the 95% prescription dose covered at least the 95 of the planning target volume. The maximum hotspot accepted for this case 110% prescription dose. Those constrained to the organ at risk, the follow RTOG 615. Again, I will finally plan evaluation. If you got the bad result for the organ at risk or the underdose for the coverage, we need to communicate with the physician how to manage this this area crowded for the organ at risk and the BTV, and which the priority will accept and go to get the best plan for our patient. This is the plan evaluation by the RTOG and the clinical goal. I got the pass for all goals set for this plan, but I will explain for this slide. Sometimes we cannot get the best plan for organ at risk if organ at risk the overlap with the BTV can take not passed for some the criteria acceptance, can get for the priority for the BTV if the physician want that. This is the different serial cut for BTV, different the BTV transition, BTV 70 and the BTV 60 and the BTV 54. Finally, I will give your advice. Nasopharyngeal case during the patient that take the session, will follow the setup the patient and make sure the good the delivery treatment for the patient during the all the session. Follow that by the image guided radiotherapy and the best image guided the CBCT. Please, if you build your plan, make sure follow the alarm for the organ at risk. If the patient the lose his weight or the mask make the gap, some organ at risk inside the BTV, and the more the hard plan will get, because that start the get the best result for the organ at risk and BTV coverage for the patient. I will explain the adaptive radiotherapy. It refers to the imaging feedback control, the strategies with the treatment plan, and the modification in the response to the patient-specific treatment variation during the course of the radiotherapy. An example of the adaptive radiotherapy includes the rescan and the replan. Will make again the replan for our patient if they get the good response for the patient, and get the gap for the mask, and the therapist will communicate with the physician to make again the rescan and the replan for this patient. Many nasopharyngeal case patients that can experience the significant weight loss during 6 to 7 weeks of the radiotherapy. The patient having the significant weight loss tend to be accompanied by the reduced skin separation at the various level of the cervical spine and the neck, causing the significant interfraction to set up instability. The new radiotherapy plan will then be used for the remainder of the treatment, will intend to increase the precision of the target volume coverage and the reducing the overdose. If we don't, the replan and the resim for this the patient the missing the target and the take overdose for the organ at risk. This dimension in the slide for the explain how to the patient get the change for the BTV during the session. And thank you, and I hope give some information about this case. Thank you, Dr. Muhammad. Thank you, Dr. Romay.
Thanks, Dr. Bilal, for this interesting presentation. Very informative, step by step. I really enjoyed it. I hope everyone else enjoyed it as well. Please, do you have any question for Dr. Bilal? If you have any questions, just you can type it in or raise your hand, and I'll pass the mic to you. I have a question here, Dr. Bilal. In case of two arcs, they don't cover the target, and the third arc is used. What should you? Can you see it, Dr. Bilal? No. Yeah, if you can, you can.
I with you, Dr. Muhammad. I with you.
Yeah. Okay. So, and the third arc is used. What should be the starting and the ending angles with the collimated angle?
Third arc.
Yes. Is the first arc, second.
I used for this case 2 arcs only.
2 arcs. Okay.
Yeah, I used for this case 2 arcs only. First arc cover the first area interest, and the second arc the missing the area to get the full modulation for the MLC and the field size. If you see field size, the 15 centimeter in this slide.
Okay, I hope this answers the first question for MedPhys or MedPhy. The second question he has or she was, which is the best for the LMC model, the smart LMC or LMC variant, and why?
MLC, as I explained for this presentation, the MLC, and Dr. Mahmoud Fishawi last presentation also explained the limitation, some limitation the MLC in the variant. Maximum the leaf span for the XJO, the modulation in the XJO, maximum leaf span, as explained this slide, 15 centimeter. If make the one arc the full coverage for the for all BTV, will get the missing the modulation in this area. I mark it for this because that
Yeah.
we make split for our arcs to get the full modulation and the best the result for the BTV distribution and the organ at risk.
Perfect. Thanks, Dr. Bilal. Hope this answers the question. Any other question? Okay, I have just a small question for you, Dr. Bilal.
Welcome.
You can do a very good plan on the planning system. So what you are doing actually in your center or institute to verify the deliverability of this plan? I mean, what kind of patient-specific QA you are doing in your center?
We doing the patient specific for nasopharyngeal case or the different VMAT cases by the use the 3D phantom the by IBA system to check the patient before start for the full arc and without the deviation for the dose distribution and get the passing rate with the for the nasopharyngeal case and all the most common case in our center here by the local passing rate greater than 95 to 97%.
Perfect. Thanks, Dr. Bilal. I have here a couple of comments from Naja. I used SIB for these cases. I worked with the True Beam, and in the optimization started with the auto crop, and I get good results.
Yes.
Yeah, good.
Yes. If you use the auto crop, I will explain the three ways. If you prefer to use the BTV crop and the BTV CC by the measure the CC inside to each other and the auto crop option, the three ways will get the best result for this case.
Okay. Another question here. Second arc will be different collimator? Question mark.
Yes, second arc with the different collimator to the make the different simulation, the different those fluents. First arc, I make it. I will go back again. First arc the 20 angle degree, and the second arc the 340 collimator degree.
Okay, so different collimators. The question was for LMC, the leaf motion calculation, not the MLC. So the question was, which is the best LMC, leaf motion calculation model, the smart LMC or LMC variant? That was the question.
No, default LMC variant. Default, by default.
Default, yeah.
Default, yeah.
Okay, I hope this answered you. Any other questions, everyone? This is a recorded session, so it will be available on the RNG YouTube channel, and we are going to put the link in the Beam Hub, and it will be in the Radiotherapy knowledge group. So if you can see my screen here, it will be down here. So we're going to share it in the knowledge base group. And also there will be a second session for this topic, and it will be announced soon. It will be Friday, I think, next week. This will be announced soon. And also we have a couple of coming presentation or session soon. So keep eye on the live webinar as well, if you would like to join those ones in the near future. And here, once we share the presentation in the radiotherapy, you can ask and put your question, and Dr. May or Dr. Bilal will answer you. Okay, once more, thanks everybody for your time today, and hope you gain some information from out of this presentation. And have a nice weekend. Thanks, everyone.